You've probably learned a lot about studies in which people test medications, maybe testing the effects of Prozac on depression or something like that. And in all these studies, there's a group of subjects who gets Prozac and a group of subjects who gets a placebo, and none of these subjects knows exactly what they got. Probably you take it for granted that any study of a medication must have a placebo control group, and you would all probably scoff at a study of a medication that didn't have a placebo control group. And of course, for any big pharma company to get its drugs on the market, it has to include a placebo control group in its drug trials. So, if you believe that studies of whether drugs work require placebo control groups, then by definition, you believe that people's beliefs affect their health. Placebo effects are one of the clearest pieces of evidence we have that there's a link between people's beliefs and the state of their body. Here's a great video that gives you a quick overview of everything we're going to be talking about today in this video.
Now, you've all heard of the placebo effect before, when something with no known therapeutic value can actually make people feel better. It's a great trick our minds play on us, that by believing and expecting something to work, it actually does. But what's weird is that the strength of the effect can differ for some really strange reasons. For example, the same placebo can treat pain half as well as aspirin, while at the same time treating pain half as well as morphine. Morphine's a much more powerful painkiller, but a placebo is half as effective as both? Saying a placebo will reduce pain reduces pain, but saying that the same placebo will increase pain increases pain. Believing that a placebo will make you feel better will make you feel better. Believing that it won't has the opposite effect. Now, placebos aren't just pills. They can be creams, injections, surgeries, or drinks. You can even get placebo buttons. They don't actually do anything, but they sure as hell make you feel like you're in control. But not all placebos are equal. The effect of the placebo is bigger when the pill itself is bigger, or if you have 2 instead of 1, or 2 once a day instead of 1 twice a day. And a capsule will usually beat a pill, and a syringe will usually beat a capsule, and anything with a big ass science machine can outperform any of them. A plain pill works worse than a branded one. A discounted pill works worse than a pricey one, and even a pill in a plain box does worse than one that's all shiny and shit. Placebos that are blue work best as downers, and placebos that are red are better as uppers. Studies have shown that people who take their meds on a regular basis are less likely to die than those that don't, even if those meds are all placebos. You can even get addicted to placebos. In one study, a group of women took placebos for more than 5 years. 40% of them suffered withdrawals afterwards. In fact, the effect of placebos can be so strong that some people want them banned from sports. But I mean, how would you even test for that? Placebos don't even seem to work from place to place. For example, in Germany, using a placebo to treat ulcers works better than anywhere else in Europe. But using a placebo that treats hypertension doesn't work nearly as well as it does for its neighbours. Now remember that all of this is about comparing things that both have nothing medically effective in them, which goes to show that a placebo isn't about what's in it, but about the beliefs that we load onto it. Our minds create the medicine, and that is pretty freaking weird.
Okay, so that was a lot of information, but we're basically going to talk about all the major points the previous clip just made. So remember way back in the first week of class, I gave you a historical overview of how sickness has been viewed across history. I talked about how in the Stone Age, people thought diseases were caused by evil spirits in the head, and so they cured diseases by puncturing sharp holes in sick people's skulls to let these evil spirits out. And I also talked about how in the 1800s, people thought illness was caused by capillary tension, so they cured these illnesses by doing bloodlettings. Well, that was just the tip of the iceberg. In every era, people have been making a variety of different concoctions that were supposed to cure illnesses. The point I want to make here is that as long as people have tried to treat illnesses, there have been placebos. The Egyptians used lizard's blood, crocodile dung, the teeth of a swine, the hoof of a donkey, and putrid meat as treatments to cure all sorts of diseases. One widely used placebo was called theriac, which took from months to years to concoct. It had anywhere from 30 to 100 ingredients in it. It was first formulated by the Greeks in the 1st century. The main ingredient was viper's flesh, which made sense because vipers shed and grow new skin, suggesting a sort of rebirth, which of course should be beneficial in treating many illnesses. Some also thought that including a part of a dangerous snake would help treat poisonings. The treatment began as a preventative against any type of poison, and then eventually was used to treat pretty much everything. Another remedy, called unicorn's horn, sold for 10 times its weight in gold. This unicorn's horn was similar to theriac in that it was seen as an all-encompassing cure. Use of this treatment lasted from the Middle Ages all the way up until the 18th century, which is when they discovered the narwhal, which is the marine animal that possessed a tooth that people mistook for the unicorn's horn. The drug most frequently cited by Shakespeare is mandrake, which was used to treat pretty much every ailment. I mention that because mandrake appears in numerous stories, including Harry Potter, in which it was used in a magical potion, and in Pan's Labyrinth, in which it was used to treat a difficult pregnancy. One of the side effects of ingesting mandrake is delirium and hallucinations. Since this root actually did lead to physiological changes, it's easy to see why people would think that it had some kind of curative power. Anyway, people went to great effort and paid huge amounts of money for these treatments and drugs. And they didn't do it because these drugs didn't work. They spent this money because these drugs did work, at least when the side effects of these cures didn't kill you. All of these remedies are examples of the power of placebo effects. One slightly cynical historian named Norman Cousins has said that the history of medicine is the history of the placebo effect. However, others have had somewhat nicer comments regarding placebos. Thomas Jefferson saw placebos as a pious fraud, and Voltaire, an 18th century philosopher, viewed physicians as the placebo. He said, "A good physician is the man who successfully amuses his patients while nature effects a cure." If you think about sick people, there are really only 3 things that could cause sick people to get better. First, natural history effects. The ailment simply runs its course. Many problems just resolve themselves, such as the cold or the flu. There's a famous saying that a cold will last for 7 days if you treat it, and about a week if you leave it alone. A second way in which people can get better is through some treatment that helps because of the specific active components of a drug or a surgery. So, for example, the chemical in a drug that leads to changes in some chemical in the body that leads you to get better, or a surgical procedure that actually repairs a damaged organ. And then the final possibility is the placebo effect, which results from non-specific effects of a certain treatment. A placebo is any medical procedure that produces an effect in a patient because of its therapeutic intent and not its specific nature, whether chemical or physical. A placebo effect is something that causes an effect because of the intentions surrounding the placebo and not because the placebo itself causes any changes in the body. Placebo effects are so common that all studies testing the efficacy of new drugs must have a group that gets a placebo. As I mentioned earlier, this is the only way for new drugs to make it to the market. To show that a new drug is worthwhile, it has to be better than just a placebo. That makes sense if you want to learn about the new drug, but it doesn't really tell us anything about the placebo itself. Unfortunately, most of the information we have on placebo effects comes from studies testing new drugs. These kinds of studies are called double-blind placebo-controlled studies. Half the subjects get the real drug, and half the subjects get the placebo, and neither the subjects nor the researchers know who got what. All that placebo-controlled studies of drugs can do is compare the placebo to the active drug. So generally these studies show that the active drug is better than the placebo, but these studies are unable to show that the placebo is better than no treatment at all. If you want to do a study comparing a real pain medication to a placebo medication, for example, and the real medication relieves the pain of 65% of your subjects, and the placebo relieves the pain of only 45% of your subjects, all you really know is that the real medication performed better than the placebo. You don't know if the placebo medication is better than nothing. It's possible that those 45% of patients who got better could have just gotten better through natural history effects. So the illness cleared itself up. Again, this is good enough for showing that the real drug works, but it doesn't tell us anything about the placebo. To show that a placebo works, you need to show that it's better than nothing at all. So to show that placebo effects work, all you really need is a two-group study where one group gets the placebo and the other group gets nothing. The most convincing way to show that a placebo has an effect is to do two things. First, you ideally want three groups: a group who gets an active drug, a group who gets the placebo, and a group who gets nothing at all. To show a placebo effect, the placebo group should be better off than the group who got nothing at all, and it would be especially convincing if the placebo group did just as well as people in the active treatment group. Plenty of studies have documented placebo effects using these three-group designs. Just to give one example, a researcher dug up all the studies of placebo antidepressants and looked at all their results together. He found that the patients given the placebo antidepressant showed 4 times as much relief from their depression symptoms as patients who were given nothing at all. And frequently, the patients given placebos did just as well as people given real antidepressants. So this should dispel the number one common misconception about placebos, which is that giving a placebo is the same as doing nothing. This is exactly not what's going on. A placebo must be better than doing nothing to be considered effective, and people given placebos respond in very different ways than people given nothing. In fact, only certain situations lead to placebo effects, and we'll talk about those situations in a few minutes. The second thing you'd ideally want to do is have objective measurements of some outcome. If you don't have an objective measure of the outcome, people can argue that placebo effects are simply demand characteristics of the situation. So, in other words, they just reflect subjects or patients wanting to tell doctors or experimenters what the doctors or experimenters want to hear. Lots of placebo studies involve self-reports, so for example of pain, or of other symptoms that doctors can't really determine for themselves. And those have value, and we'll get to that later. But ideally, you want objective measures of outcomes. And there are plenty of studies that use measures of symptoms that are more objective. And these use independent ratings of symptoms, ratings of people who don't know what treatment the patient was given. So, for example, several placebo studies look at the formation of warts or rashes on people's arms after they've been exposed to placebo allergens. In one of these studies, the subjects were people with hypersensitive skin. In this study, the subjects were touched with harmless leaves, a placebo, and they were told that it was actually poison ivy. All of these subjects developed a rash on their arm. But these same subjects, at the same time, but on their other arm, were touched with poison ivy leaves, but were told that they were being touched with harmless leaves. And guess what? They didn't develop a rash on that arm. So subjects can tell doctors that they feel sick to satisfy the doctor's expectations, but they can't make a rash magically appear or not appear. So the placebo effect isn't just subjects trying to be good subjects who say what their doctors want, who say what they think their doctors want them to say. This should dispel another misconception about placebos, which is that people who respond to placebos essentially have nothing wrong with them to begin with. This, frankly, isn't true. Research documents people with legitimate, observable symptoms that go away or appear after being given placebos. The company that makes the hair-growing drug Rogaine did a placebo-controlled trial on hair growth using Rogaine, and they found that 39% of the patients in the placebo control group grew significant amounts of hair, compared to 63% of participants in the experimental group. They didn't have a no-treatment control group, but it's widely believed that no new hair growth of any kind would have occurred without some kind of treatment. In fact, showing any new hair growth at all is pretty unusual. A second example comes from a study looking at the effects of placebo acupuncture on irritable bowel syndrome. In this study, the patients all had irritable bowel syndrome, which is a chronic gastrointestinal disorder characterized by recurrent abdominal pain and disturbed bowel function. The researchers compared patients in a waitlist control group, so in other words a no treatment condition, to patients given sham acupuncture. A sham acupuncture device doesn't actually pierce the skin, but it creates the illusion of doing so because of how it retracts into a hollow handle. The subjects and the subject received these sham acupuncture treatments twice a week for 3 weeks. These subjects showed more improvement in their symptoms, and more of them reported getting adequate relief from their symptoms after 3 weeks of treatment. A third example comes from a study investigating a placebo treatment of knee pain. Knee pain is a pretty common problem in the United States. About 6% of the adults in the U.S. population and 12% of the elderly suffer from frequent knee pain as a result of arthritis and inflammation in the joints. An estimated 650,000 patients each year undergo arthroscopic surgery for arthritic knees at a cost of $5,000 each, so more than $3 billion in total, and insurers routinely reimburse this expense. The team doctor for the Houston Rockets basketball team did a study of placebo arthroscopic knee surgery. By arthroscopic, I mean the surgery involves just cutting 2 to 3 small holes in which a doctor can insert medical devices to repair any damage he finds. In one group of subjects, they did the real arthroscopic surgery, and in another group of subjects, they did a placebo surgery. In this placebo surgery, they sedated participants with a tranquilizer and a narcotic. However, just in case the patients didn't completely fall asleep, medical staff splashed their knees with water, much as they would during a real procedure. To fool the placebo patients further, the researchers ran a video of someone else's knee operation on monitors above the operating table, standard procedure for doctors operating through scopes used in arthroscopic procedures. They made 3 stab wounds in the knee, but used no surgical instruments or procedures other than that. When the sedatives wore off, the patients found a fresh incision on their knee. All the patients in both groups fully recovered their ability to walk, and in the same amount of time. During 2 years of follow-up, the patients who went through the sham surgery fared as well in their perceptions of pain reduction and knee function as those who had the real arthroscopic surgery. In fact, at several points, patients who got placebo surgery reported better results than some of the surgery patients. And 40% of the subjects in both groups completely recovered. The media used this as evidence that arthroscopic knee surgery doesn't really work, but the story really could be that placebos do work. We really need the no treatment control group here to tell for sure. There are a lot of studies showing that placebos can be remarkably effective in relieving pain. In fact, pain relief is probably what placebos do best. Some people will discount these studies because pain relief is self-reported, but they shouldn't. Pain is always self-reported. The only way we can measure people's pain is to simply ask them about it. And people in pain aren't particularly likely to lie and tell you they feel better if they don't. If a placebo causes somebody to report pain relief, that's great, because we want people to not be in pain. An early example of this kind of study comes from a researcher who compared morphine with a placebo. Patients who were in pain were injected with either morphine or a placebo. Now, as you probably know, morphine is a really strong painkiller. So, of course, it was significantly more effective in reducing pain than the placebo. However, the placebo was a successful painkiller in 35% of this researcher's cases. So 35% of the people receiving placebo had reductions in their pain. A more recent example comes from researchers looking at the effects of placebo topical creams on pain reduction. Participants in this study completed 2 separate test sessions, separated by 1 to 8 days. At each session, the participants had one finger on each hand injured. One hand wouldn't receive any treatment at all, and for the other hand, the researchers would place a topical cream. In one session, the researchers said the cream was ibuprofen, which most people would recognize as a non-aspirin pain reliever. And in the other session, they said the cream was trivaricaine, which they claimed to be a hospital pain reliever. Of course, in both sessions, the creams were inert, so they were placebos. However, participants experienced greater pain relief with both creams compared to nothing. Research was conducted a few years ago that tried to dig up every study that compared subjects in a placebo group to subjects in a no treatment control group. They found 130 of these studies. They pooled all the results and found that placebos do better than nothing for pain, and placebos are better than nothing in studies where the health outcome is measured subjectively. So, for example, by asking subjects how they feel. Some of the studies also showed significant benefits even when the health outcome was measured objectively, but only when it was measured continuously. So for things like breathing in asthma patients, they didn't find any differences between placebos and no treatment control groups for health outcomes measured objectively with binary outcomes. So for things like, does the individual have depression, yes or no? Since they didn't find significant differences among all classes of studies, the researchers concluded that placebo effects don't actually happen, that placebos don't work. Their analysis was highly controversial. One reason is that their results really suggest that placebos can be beneficial for treating pain and for treating symptoms with self-reported outcomes. A recent study of placebo treatments for asthma had findings that basically fit right in with the general summary of the meta-analysis we just talked about. In this study, the researchers used a within-subjects design to test 4 treatments. In other words, every subject underwent all 4 treatments. The subjects were people with asthma, and the 4 treatments were albuterol, a placebo inhaler, a placebo sham acupuncture, and a no-intervention control. Then the researchers measured a subjective and objective outcome. The subjective outcome was patients' self-reports of improvements in their symptoms on a rating scale from no improvement to complete improvement. The objective measure was forced expiratory volume, a measure of how well they could breathe. They found that when they used the objective outcome, only the albuterol, the real treatment, led to improvements. That's what this graph is showing you. The x-axis is showing you the different treatments, and the y-axis is showing you change in their maximum forced expiratory volume. So on this measure, the placebos were no better than the no intervention group in terms of helping these patients breathe. But when the researchers used the subjective outcome of reported improvements in symptoms, both of the placebos worked just as well as the active treatment, the albuterol, and they worked better than the no intervention control group, and that's what this graph is showing you. Again, the x-axis is the different treatments, and the y-axis is participants' subjective improvements. So this study shows placebos leading to subjective benefits, but not objective ones. And you definitely see more subjective benefits from placebos, but you do also occasionally see objective benefits. There are a lot of ailments that placebos have been shown to give at least some relief for. This is a partial list, but it includes some of the more common ailments that placebos help. I should also tell you that there are plenty of ailments where you never hear of placebo effects happening. So you never hear of placebo effects with cancer or anything doing with HIV, and you don't hear of placebo effects helping patients with dialysis due to kidney disease, nor do you hear of placebo vision impairments or hearing impairments or anything like that. So placebos do have their limitations, but it's crazy to deny that placebo effects don't happen, because they really do happen quite frequently. So what affects whether or not placebos work? I'm going to go over how each of these 4 factors, healthcare provider benefits, characteristics of the patient, situational factors, and social norms, impact the effectiveness of placebos. The first factor is the behavior of healthcare providers. If a doctor exudes warmth, confidence, empathy, reassurance, and competence, then you'll get a stronger placebo effect. Furthermore, if the doctor seems to believe in the curative powers of the treatment being offered, then you're more likely to show a placebo effect. So, if the doctor acts as if the placebo will work, then it's more likely to. Placebo effects tend to also be stronger when providers take time with their patients and don't make them feel rushed. The last thing providers can do to strengthen placebo effects has to do with patient-provider communication. Obviously, for a placebo response to occur, a doctor has to take enough time to talk with their patients so that their patients understand what the treatment's supposed to do and how to properly take it. In one study, patients were given a tranquilizer by a doctor who either expressed confidence in its effectiveness or doubt in its effectiveness. When the doctor expressed confidence in its effectiveness, it was found to be effective in 77% of patients. When the doctor expressed doubt in its effectiveness, it was only effective in 10% of patients. It's important to make clear that this study used an actual drug, but the placebo effect still holds because the doctor had confidence in the medicine, and that led to even greater relief when the doctor expressed confidence. Characteristics of patients also impact the strength of placebo effects. Most basically, the patient's expectations matter. Placebo effects won't happen if the patient doesn't think the treatment will work. There's a myth that there is a placebo-prone personality, and a lot of effort in the early years of studying placebos went into trying to pin down what this personality type might be. What they thought was that there were certain types of people who would always show placebo effects and certain types of people who wouldn't. But they were unable to find this, and researchers have since given up on finding this placebo-prone personality. There's still research out there suggesting that different personalities are more or less susceptible to placebos, but overall there's just not enough evidence to prove that there's a placebo-prone personality. People vary over time and situations whether or not they'll show a placebo effect with a particular treatment. A person might show a placebo effect today, but not tomorrow. The only finding in this area that hints at individual differences in susceptibility to placebo effects is that anxious people show a stronger placebo effect, stronger susceptibility to placebo effects than less anxious people. However, researchers believe that this has nothing to do with their personality characteristics. Instead, they believe that it's related to the physiological symptoms that anxious people suffer from. Highly anxious people tend to exhibit a lot of physiological arousal, and when they take a placebo, their anxiety might begin to decrease, which will dampen this physiological arousal. The characteristics of the placebo also influence its effectiveness. Placebo effects are stronger in settings with all the trappings of medical formality. So settings with people in uniforms and machines making all kinds of beeping noises and medicines and tongue depressors, etc. Also, the more a drug seems like medicine, the more effective it'll be. Instructions that seem very medical, scientific, and precise are more effective than casual, imprecise instructions. So, prescriptions for exercise or changes in diet show much weaker placebo effects than pills or medications. Also, drugs with a known name, so named brand drugs, are more effective than drugs with an unknown name. Other factors include characteristics of pills. Expensive pills are more effective than cheaper pills, injections are more effective than capsules, and capsules are more effective than tablets. Also, pills that are foul-tasting tend to be more effective than good-tasting pills. And even the color of the pill matters. Placebos in cool colors work better at sedating individuals, whereas pills in warm colors tend to work better as stimulants. The culture people belong to also impacts the kinds of placebos that tend to be effective. In our culture, there's a norm to believe that drugs work and to have faith in them. In the U.S., people spend more than $100 billion each year on prescription medication. So that's just for prescription medications. That doesn't even include the money you fork over for Tylenol or ibuprofen or any other over-the-counter medication. So people believe drugs work and have very few experiences that disconfirm their faith in drug taking. And if you're sick, take a drug, and then you get better. You generally attribute your recovery to the drug rather than the possibly more likely to be correct attribution that the illness just ran its course. If you don't get better after taking a drug, you just assume that it was the wrong drug and you switch drugs until you find the right drug, i.e., the illness eventually runs its course. not all cultures have this norm, and so it's not too surprising that there are differences between cultures in how effective placebos are. So, for example, in Germany, across 5 studies of placebo effects, placebos helped about 59% of subjects. In Brazil, across 3 studies of placebo effects, placebos helped only 7% of subjects. So a lot can probably be learned about placebo effects by studying them cross-culturally. So how do placebos work? Well, nobody really knows for sure, but there are several hypotheses out there. I'll explain each hypothesis and then provide some of the evidence supporting each of these hypotheses. Each of these explanations can account for some placebo effects, but none of these explanations can account for all placebo effects. So I'll do my best to clarify which explanations can account for which types of placebo effects. The first hypothesis for why placebos work is that placebos decrease anxiety and thus may reduce the physical symptoms associated with anxiety. So, for example, upset stomach, diarrhea, or trouble sleeping. Researchers were never really huge fans of this argument in the first place because the things placebos help aren't always things that have a lot to do with stress. However, this does help explain the findings of why anxious people tend to be better helped by placebos. The next explanation for placebo effects is the endorphin argument. Endorphins are chemicals that are naturally produced in the body and that have the same effects of opiates, which, as you'll learn later when we talk about pain, are the most potent kind of painkiller. Endorphins are the things that are released after extensive exercise that produce the so-called runner's high that keeps marathon runners from just quitting midway through the race. I guess I've never ran far enough to experience a runner's high because I've never felt anything positive while running. The argument for this explanation is that when you give someone a placebo, their body releases endorphins, which relieves their pain. Placebos do a lot of things in addition to reducing pain, as we've shown in previous examples, so endorphins couldn't account for all placebo effects, just the pain-related ones. One bit of support for this explanation came from a brain imaging study, which showed that people who reported pain relief after getting a placebo pain reliever had activation in their opioid receptors, the place where endorphins work. There's another argument for the endorphin explanation that comes from studies on placebos versus drugs that actually block opioid receptors. All this information can become pretty confusing really fast, so I'm just going to give you the basics. So Levine and colleagues have done several studies where they compare a pain reliever, a placebo, and naloxone, which is a drug that actually blocks opioid receptors. If your opioid receptors are blocked, endorphins can't enter the receptors, and therefore you shouldn't experience any pain relief. In these studies, they found that if they gave participants naloxone after giving them a placebo, then the placebo effect wore off pretty much immediately. A lot of their studies focused on pain relief after going through a dental procedure, such as having your wisdom teeth removed. However, these findings have been supported in other contexts as well. However, these findings only work for placebos that are meant to be pain relievers. One last thing before moving on to the third argument is an ethical consideration of placebos. One ethical consideration regarding the effect of placebos on endogenous opioids involves the ethics of sports. In a recent study, researchers used placebos in an experimental simulation of a sporting event, whereby a placebo was given on the competition day after preconditioning the placebo with a narcotic during a training phase. So they were relying on classical conditioning to invoke the placebo effect. They found that after repeated administrations of morphine in the training phase, the administration of the placebo on the day of the competition led to increased pain endurance and improved physical performance. The researchers were able to determine that this was because of an increase in the endogenous opioids inside these athletes. In other words, these athletes who were preconditioned with morphine and then given placebo during the actual competition were producing their own morphine. So this shows that athletes can be preconditioned with narcotics and then given a placebo just before a competition, thus avoiding the administration of illegal drugs on competition day. These narcotic-like effects of placebos raise the important question of whether these processes are ethically acceptable in sports or whether they should be considered as a kind of doping. The next explanation, which I just hinted at, is that placebos work because they get conditioned to work. This is the classical conditioning argument. So, for example, drugs, procedures, or doctors can become associated with things that really do work. They can get conditioned, just the way that Pavlov's dogs got conditioned to salivate every time a bell rang after the bell was paired with food on several trials. The argument says that placebo effects could be some sort of conditioned symptom reduction, in which, for example, morphine paired with a needle leads to pain reduction many times in your life, so later, when you get the needle alone with some placebo medication in it, you end up with pain reduction. One researcher has found that conditioned pain relief is much more effective if the person has prior experience with an effective pain reliever compared to only experience with less effective pain relievers. On the other hand, there's a bunch of evidence that many placebo effects can't be working through classical conditioning. The arguments tend to get a little bit technical, but they basically involve showing examples of placebo effects that violate the rules of conditioning. And I'll mention these arguments briefly here. First, one of the rules of conditioning is that if you keep presenting the conditioned stimulus without the unconditioned stimulus, so if you keep presenting the needle without the morphine, over time, the needle with the placebo medication is going to lose its effectiveness in reducing pain. And people who study conditioning have documented that extinction actually happens quite quickly. But in the studies of placebos, the effects don't go away or even get weaker over time. And in fact, the effects last much longer than expected, and the strength of the effects even seem to increase over time. Second, lots of times placebos do the opposite of what they're supposed to do. And if they do the opposite, there's no way that they could have been conditioned to work. One example of this is a study of women who were severely nauseated. The researchers gave these women ipecac, which is a substance that makes you vomit. Anyway, the researchers gave these nauseated women ipecac, but told them that it would make them less nauseated. And in fact, it did make them less nauseated. These responses couldn't be attributed to conditioning because these subjects had never been given ipecac to decrease nausea. Third, and this is somewhat similar to the second explanation, but lots of times placebos behave differently than the real drug behaves, but similarly to how people assume the drug works. So, for example, giving people placebo alcohol causes them to behave however their culture thinks alcohol makes you behave, and not according to how alcohol actually makes you behave. All these arguments against the conditioning explanation actually support the fourth explanation for placebo effects: expectations. The argument is that placebo effects are partly mediated by classical conditioning, but partly by cognitive factors, like expectations. Conditioning may set the stage for placebo effects, but expectations and situational factors influence and determine the nature and magnitude of the placebo response. But prior experience isn't required to have the placebo effect. If it was, that would suggest a pure conditioning argument. But since you can have a placebo effect without prior experience with a drug, it suggests that your expectations about what a drug is going to do to you is enough to get the placebo effect to work. One thing that suggests that placebo effects are determined in part by expectations is that the more believable and technically convincing the placebo is, the more likely it is to work. Remember, placebo injections are more effective than placebo pills, and placebo morphine is more effective than placebo aspirin. Other support for the role of expectations is the example I gave you a moment ago, in which some drugs, like Ipecac, will do the opposite of what the drug actually is intended to do. If the doctor suggests that will be the case. In fact, you don't tend to see placebo effects occurring in the absence of some sort of expectation or suggestion about what the drug will do. You won't see placebo effects where you give the drug while the person is sleeping, for example. The person has to develop some kind of expectation of what the drug's going to do. Also, every time a placebo effect works, this improves the likelihood that the placebo effect will work again. This, again, goes against the conditioning argument, which suggests that every time you administer a placebo, the effect gets one step closer to extinction. But with expectations, placebo effects are self-confirming. You see the placebo effect work, which increases your expectation that it will work again, and that makes it more likely to work again. One study that people sometimes use as support for an expectation argument is a study of the effects of placebo caffeine. In this study, researchers gave subjects decaf coffee, but told them that it was actual coffee. Then they showed them this monitor task that they had never seen before. For 1/3 of the subjects, the researchers said that the caffeine would improve their performance on this task. For another third, the researchers said that the caffeine would hurt their performance on the task. And for the remaining third, the researchers didn't say anything about how the caffeine might affect their performance on the task. And sure enough, subjects who were told caffeine would help their performance did the best on the task. Those who were told it would hurt their performance did the worst on the task. And the subjects who were provided with no information were somewhere in the middle. With that said, I should point out that claiming that placebo effects happen because of expectations doesn't really explain how they happen. How does the expectation lead to physical change? There's a whole bunch of steps somewhere in the middle that we have no explanation for. It's just one of those, and then a miracle happened, types of explanations. Finally, we'll finish this video with a brief discussion of nocebos, which are just like placebos, but they cause an unpleasant effect. Nocebo effects aren't very well studied, but a nocebo effect would occur, for example, if your doctor gave you a sugar pill, claiming it would make you nauseated, and then after taking the sugar pill, you vomit. And one study did just this. The researchers placed one group of participants and in a condition in which they were given sugar water, and where these participants were told that it would make them nauseated, and 80% of these participants actually vomited. You don't typically vomit from drinking sugar water. Another example of a nocebo effect is what's known as the medical student syndrome. Medical student syndrome is when medical students start to develop symptoms of a disease that they're studying. 79% of medical students say this happened to them at least one time in medical school. The symptoms and anxiety usually go away in a couple of weeks, usually after somebody tells them that they're being ridiculous. Psychology students do a similar thing. They start to think that they or people close to them have all these different mental illnesses that they read about. A third study looked at both placebo and nocebo effects. Asthma patients were given saline solution, an inactive substance, in an inhalable form, but they were told that it was some sort of irritant that could cause problems with their breathing. Sure enough, half of the participants experienced serious problems with their breathing, and a subset of them had full-blown asthma attacks. Then, all those participants who were having these nocebo side effects were given the same saline inhaler, but this time were told that it was a substance that would help them feel better. And in fact, this improved their symptoms. So first, the saline acted as a nocebo effect, the effects of which were cured by a placebo effect using the exact same saline solution. This study pretty clearly shows how our expectations can affect our health. In terms of studying nocebo effects, there's an ethical quandary. In studies of nocebo effects, unlike in studies of placebo effects, you expect to hurt subjects. You're giving them something harmless, but you fully expect to hurt them in some way. So how do you do that ethically? In terms of being a doctor, it's hard to know what to do about nocebo effects. Doctors have to communicate honestly to patients about what the likely side effects of a medication are, but they somehow need to do this in a way that doesn't create nocebo effects. They don't want to plant a suggestion of potential side effects that will make it more likely for these side effects to occur. Also, given the power of placebos, should they be prescribed by doctors? Well, they have 3 advantages over other drugs. They're cheaper, they have no side effects, and they're quite effective. But how can we go about prescribing placebos? Obviously, we need to tell people what sorts of medications or treatments they're getting. We have to tell people whether they're being treated with an inactive substance. Or do we? Investigators told volunteers in one placebo study that the pills they were taking were known to significantly reduce pain in some patients. After what we've learned in this video, we can't really accuse these researchers of lying.